We are producing this video on multiple patient requests. As you know, we have a very busy BBL body contouring patient community, and with most of our patients coming from abroad, of course, the topic of safety, which has been very present in press and media for the recent years, always raises the question of BBL safety, and I want to address that, with a bit more detail, to put patients' mind at ease, and I think bring a little bit more form, level, and a degree of education to this debate. I think really to answer the common question, what makes a BBL safe? I think it's key components. Technically, is EVL, expansion vibration lipofilling. I'll explain in a second what that means, and the application of ultrasound, be it dynamic or static. I will also explain now what that means. Let's start the other way around. And that is also something that patients ask me all the time. What would you say is a sign of or not such a good sign for BBL surgery being possibly unsafe? To say so, I'd say the red flags that I would recommend to consider is generally the use of syringes, the use of fine, sharp needle cannulas, manual bolus injection, which comes with syringes. If the surgeon has no traceable ultrasound experience, I think that in 2022 is also no longer good, and not focused practice. I really think this is a kind of surgery that you should do all the time, and not just occasionally between 50 other surgeries, but focus on that. Now, expansion vibrational lipofilling, to wrap it up as simple as possible, works with the vibrating handpiece on our vibrating cage cannula you see illustrated here, which is connected to a tube which brings the fat in with a roller pump that avoids boluses, gives a continuous flow, a sterile circuit, and you can do that either static or dynamic. Now, the subcutaneous fat layer you see depicted here in an ultrasound picture is variable in every patient. So what we do for the dynamic technique is we measure that with ultrasounds. We've got exact knowledge of the recipient bed. That has the huge advantage that you have your left hand free, your non-dominant hand free in that case, for palpation control, and I think you get a better dispersion. So my thesis is that it results in a little bit of a better graph take this way. Disadvantage, you can't do a real-time video documentation with this. The alternative is static, so-called semi-infiltration. That is nice, but however, the infiltration is static, so you bring the cannula to the point with your left hand. The ultrasound head, which is the mobile one, monitors the depth of the cannula, and maybe the more close up here we'll see how the fat goes in. That is also, I think, a very interesting concept, and it is actually, in certain parts of the US, it has been made a legal requirement. I mean, the challenging question is that because you can store the videos, or is that because it's better? I think it's more the documentation aspect that has been dominant here. I object, or the thing that I personally don't like so much about it is that you don't have palpation control with your non-dominant hand. And what I think time will tell us, after there's a few thousand cases done with this, if the static infiltration possibly has an unfavorable effect on fat graft take. You see here, we all have different subcutaneous fat thickness, and in a thick subcutaneous layer, I think that by mapping, basically exactly measuring out the subcutaneous tissue, you can perfectly control your infiltration depth by palpation. You just have to know how thick it is. In thinner subcutaneous layers, I think that may be more challenging, and then static infiltration might be more interesting. You see this illustrated here, and I think that makes it understandable that with the rigid cannula and the consecutive exact palpation control, you have a very, very good safety profile. So wrapping it up, I think the key is, is find somebody with really traceable long-term experience with a modern technique like EBL lipofilling. Again, credits for developing this go to Dr. Daniel Del Vecchio from New York. It is the backbone of cutting-edge technique in BBL. And my submission: for thin patients, you can consider static. For thicker patients with a subcutaneous fat layer over 3 centimeters, I do think that dynamic ultrasound may be the better solution, but any kind of ultrasound in both ways employed adds on to safety. So I hope we've made this understandable, and hope that this disperses a lot of doubts and gives more security, information, and education on how to do this safely.